Today we're going to talk about conditions originating in the perinatal period, which is chapter 16, and congenital malformations, deformations, and chromosomal abnormalities in chapter 17 in the ICD-10 CM codebook. We'll begin with chapter 16. Codes in chapter 16 are never for use on the mother's record. Likewise, codes from chapter 15, the OB chapter, are never permitted on the newborn record. Chapter 16 codes can be used throughout the life of the patient if the condition is still present. And for coding and reporting purposes, the perinatal period is defined as before birth through the 28th day following birth. When a physician is talking about a premature infant, typically they talk about the birth weight and the gestational age of that infant versus using the term premature. There are P05 and P07 categories that relate to low birth weight and gestational age. Codes from P05 should not be assigned with category P07 codes. And there is an excludes one note with the P07 that reminds you of this. And also in the instructional note under the P07 category, it reminds the coder that when both birth weight and gestational age are available, we're going to choose two codes from P07. The code for the birth weight will be sequenced before the code for the gestational age. In this example, the baby was born small for dates, and what that means is it was full term, but it weighed less than the doctor thought it would weigh, given that it was full term. And the doctor tells us that her weight at birth was 1,770 grams, and the doctor suspects the baby has problems because of her mother's use of chemo before the mother knew she was pregnant. So I have the rationale and the pathway here on the right. We're going to look up small for dates, and using the range of weights that's given, P05.17, and the newborn affected by the maternal use of medication, there was no subterm for chemotherapy, so I chose the medication subterm as the closest thing. In this example, we're looking at the P07 category when both the birth weight and the gestational age were given to us. And following our coding guideline, the birth weight code goes first, then the gestational age. And in this case, the P07 category code is used for a child that was premature at birth, and her prematurity has affected her development. So you're going to put your P07 codes and then do your developmental delay codes for the motor coordination and the speech. In this example, the Z38 code is your principal diagnosis because we are coding the birth episode. Then following that birth episode code, we're now going to code the hemolytic disease due to the ABO isoimmunization. There are the pathways on the right. In this example, we are given the birth weight as well as the gestational age, and in this particular baby, very low birth weight. And following our rationale and our pathway on the right, you see where the preterm takes you to the gestational age at 33 completed weeks, P07, and then we have the hyaline membrane disease. I put the coding guidelines on the left just because it was a little more room there. In this example, we have extreme immaturity. If you can remember a premature baby and extreme prematurity called immaturity, this is when you are less than 28 completed weeks. Very few infants live when they're so small and so poorly developed. And I use the P96.1 code to indicate the baby was in withdrawal because of the mother's addiction to heroin. Example 6, we have the infant with a hemolytic disease, and I make the notation that the patient was received by transfer from another facility. And the part of the guideline that applies in this case is that that Z38 code is only assigned once, and it's assigned at the hospital where the birth occurred. So because the case that's given to us here in the diagnostic statement, the patient was received by transfer, then we will not be using the Z38 code there. Here is example 7. And I have the pathway on the right. We are using the principal diagnosis of Z38.01. The baby was born in this hospital by cesarean. And then I have the problems that are occurring, the perinatal conditions that are occurring that are coded there. The next example is kind of long, but I wanted to just step us through it. It is a term birth, meaning it's not a premature baby, but if the baby's born with sepsis, severe sepsis, the code book does make a distinction between sepsis and severe sepsis. So when those words are used, severe sepsis, you're going to be looking at an R code. And in this case, I give you a little cheat note that amnionitis may also be documented as chorioamnionitis, because in the alphabetical index you need to know that. The Z38.00 code is our principal because the baby was born in this hospital. Then we code the sepsis code, and in this case there is a combination code for the newborn sepsis and the E. coli, and an instructional note with that category code telling us that if we have severe sepsis identified, we need to use that R65.20 code. And then we have the chorioamnionitis, and to help us in our sequencing, there's an instructional note that says code first any current condition in the newborn, and in the case of this newborn, the baby has the sepsis, and that comes in front of the chorioamnionitis code. And last of all, the sepsis code. The next example is just a reminder to us that some hospitals do keep records for stillbirths, and if you are working in one of those hospitals, you're going to simply find the main term stillbirth P95, and that is the only code you're going to have on that record. It is not used on the mother's record, only on the baby's record, and it is the only code that is on the baby's record. Now for a couple reminders for Chapter 17. We're only going to assign Chapter 17 codes when there is documented evidence of a congenital malformation, deformation, or a chromosomal abnormality. Chapter 17 codes can be principal or secondary depending on the circumstances of the admission. If you have a doctor documenting a malformation that does not have a code, then you are going to assign any codes you need to capture that manifestation. Typically, though, I find that there are codes for the things that we see the most often. In a code assignment that identifies a malformation, a deformation, or an abnormality, the manifestations are inherent as part of that, and if they were not, then you would be assigning those. As in Chapter 16, Chapter 17 can be used throughout the life of the patient, but if a malformation or a deformation is corrected, then you're going to find a personal history code or a Z code that shows that the patient had that malformation or deformation and it was corrected. And there are times when those are not diagnosed until later in life, so that the Chapter 17 codes can be used at any point in a patient's life. If you notice in the guidelines in the front of Chapter 17, they're not numbered the same way as some of the other guidelines because they're just very general. A couple that I've chosen to highlight, and one is the Tetralogy of Fallot, and I have here it's pronounced either Fallot or Fallow, depending on how your doctor or your hospital pronounces it. Main thing is that T, that ending T, is not pronounced. And pulmonary stenosis is inherent in this disorder. And I wanted to show you, I did find a couple of things on these heart conditions. This is on the American Heart Association's website. It talks about the Tetralogy of Fallot, and there's actually a heart defect that has 4 problems. And it shows us here by bullet points and by our picture exactly what it means for a baby to be born with this. It is very rare, but it does happen. I think it's 1 in 20,000 births a baby can have Tetralogy of Fallot. Also, you can see it abbreviated as T of F on the baby's chart. So here's an 8-day-old infant with Tetralogy of Fallot and pulmonary stenosis. It's a very simple main term tetralogy. Q21.3 is the code. And here we have a 7-month-old with Down syndrome and an AV canal defect. The diagnostic statement says common atrioventricular canal, but that is what that means is it's common, meaning that some of the divisions that are normally in the heart are not there. So the atrium and the ventricle, for example, could be sharing space, so now it's a common space. So what you're really coding for a common AV canal is a defect. And I have the pathway here on the right. While it is seen in patients with Down syndrome, it is not considered a manifestation of Down syndrome, therefore it would be coded separately. As I mentioned earlier, a code from Chapter 17 can be used throughout the life of the patient, and if something has been corrected, we do want to have a history code. And the example that I've taken here from your code book is 3-year-old with a history of corrected ventricular septal defect. And you find in the history codes there's a congenital malformation of the circulatory system, and I'm showing you could also have looked up a corrected heart problem. Either way, you get the same code, and you only use that code once. That's a general coding guideline. As with many of our chapters, the exercises in this PowerPoint do not address all of the guidelines. Exam questions can relate to all the guidelines covered in the chapters planned for each week. Always follow your assignment schedule with regard to specific chapter assignments. If you have any specific questions, please post it in the discussion board. Thank you so much and have a good week.